we will continue our classes, and from tomorrow classes will be at 6 p.m. Today it is 7. From tomorrow, inshallah, it will be at 6 p.m. And I'm done with my exams, and hope that you will also be ready for your syllabus to be finished as soon as possible. For Islamabad and Peshawar candidates, our hands-on session will be in first week of January, inshallah. And the days will be Friday, Saturday, and Sunday. For Lahore candidates, it will be second week of January, that is Friday, Saturday, and Sunday. And for Karachi, third week of January. So this is finalized, inshallah. The link will be sent to you guys for registration. Those who are already registered, they have not to pay any extra fee. But those who are just who will just attend the that hands-on sessions, they will have to pay. So there is no extra dues for that hands-on sessions. But the dates are finalized. There will be no change in dates. Okay, today we have a long case, and please listen very carefully, and I hope this lecture will be recorded, and inshallah. I was just fixing with the problem. The case is peptic ulcer disease along with hyperparathyroidism. So anyone here who has already prepared this case? That's nice. Dr. Sajid, I am so impressed that you always raise your hand on first occasion. Okay. So let's start. There is a patient who presented to you with hematemesis. You have managed the patient in emergency, and your consultant advised for esophagogastroduodenoscopy. The findings are there are peptic ulcers. Biopsy was taken and there was no carcinoma. Blood investigations were done, and among electrolytes, calcium is raised, that is above 10 milligram per deciliter. So please listen the question carefully. Patient presented to you with hematemesis. You have managed the patient in emergency. Esophagogastroduodenoscopy has been done and there are peptic ulcers. Biopsy is done and it shows no malignant cells. Blood investigations have been done, and among electrolytes, calcium is raised, that is above 10 milligram per deciliter.
Okay.
So the question is, how would you define an ulcer?
An ulcer is a local defect in a mucous membrane or epithelium, like skin, due to the gradual disintegration of the epithelial cells, or it is the breakage in the integrity or continuity of a mucous membrane, epithelium or skin, due to the sloughing of inflamed necrotic tissue.
Okay, that is great. What are different risk factors for peptic ulcer disease?
Most common is H. pylori infection, and then NSAID, overuse of NSAID, and smoking.
Okay, what else?
What else? So these are the most common.
Okay, a patient who has a long-term COPD, a patient of COPD, obstructive pulmonary disease. Okay.
Okay.
So this patient has got peptic ulcer disease. What can be the cause?
Sir, smoking is the cause, most common cause.
Okay, anyone else? Steroid. So steroid is the after H. pylori and said it is steroid. Okay, and then smoking. Okay, so which part of the gut is affected mostly by H. pylori?
Uh, Sir, the most common stomach is affected mostly by the H. pylori infection.
Dr. Sajid, don't use the word sir. Okay, so if you use will use here, you will practice same in the exam. Okay, so just answer with the your uh, reply with your answer. Okay.
Okay.
So you said stomach is the most common. Anyone else? Which part of the stomach?
Antrum.
Yes, Dr. Ramsha.
Gastric antrum.
Okay. Anyone else? So for the duodenal ulcer, duodenal first part of the duodenum, first part of the duodenum, that is the most common part for the H. pylori. Okay. For
Okay, sir.
H. pylori, it is first part of the duodenum. Okay. So what is Helicobacter pylori? How will you define this organism?
It is a gram-negative microaerophilic flagellated bacterium, which is usually present in the stomach.
Which is usually found in the stomach. Okay. So which test you will do to identify this organism?
Uh, CLO test, Campylobacter-like organism test, in which we test the urease activity of this bacteria.
Okay. Any other test?
Urea breath test.
Urea breath test and
And
yes, Dr. Slan. Dr. Slan. Yes. Yes, Dr. Ramsha.
Stool. H. pylori has stool antigen.
Good. Nice. So there are three tests: CLO test, urea breath test, and stool antigen test. Okay. That's great. So how would you describe CLO test?
in this test, we take the biopsy during gastroscopy, biopsy of the gastric mucosa during gastroscopy, and then we put this sample with urea as well as some indicator like phenol red, and then bacteria produces urease, which convert the urea into the ammonia, which reduces the which increases the pH of this medium, and which this change is indicated by the change of color from yellow to the red, and which is a positive urease test.
Okay, that's good. So it has high sensitivity. It has high highest sensitivity for the diagnosis of H. pylori. Other, uh, for example, urea breath test and stool antigen test, and also the blood antigen test. So these three tests, they have less sensitivity and specificity. So this test is the most sensitive if asked. Okay.
Okay.
Okay. So which test is done for the follow-up?
For the
For
follow-up,
example,
you
you
mean
have given, yes, for example, you have given the H. pylori eradication therapy, and not for the follow-up, which test is done?
urea breath test?
Yes,
Sir,
that's
it's
good.
okay. Sorry, sir.
Okay. So H. pylori survives in which media? Acidic or basic alkaline?
Sir, alkaline.
Okay, it survives in alkaline media. Anyone else?
Sir, it actually
Sir,
trap.
in acidic media,
Sorry?
sir. It survives in acidic
Yes.
medium, sir.
Yes, yes. It loves the acid. It loves acid. Otherwise, the acid produced by the stomach would have killed it. Okay? Okay, Sajid?
Sir, but it increases the pH around itself by converting the urea into ammonia. So that's why it is protected from the acid.
So it is protected from the acid, but it survives in acidic media.
Okay,
Okay?
okay,
Yes, it survives in it. It just goes into the acidic media and then convert it into the
basic medium.
basic media. Yes. So how would it survive? What is the mechanism?
Sir, it survives. Actually, it converts the urea into the ammonium, which increases the pH of the medium, and that increase in pH basically protect this bacteria from the acidic environment.
From the acidic. Okay. So the other question, other statement of the question can be mechanism of survival of H. pylori in the stomach. In the stomach. So the statement of the question can be changed. Okay. What is the mechanism of gastritis done by H. pylori?
H. pylori basically produces different sorts of proteases and uh, proteases and phospholipases, as well as it produces toxic ammonia from the urea, which causes the irritation of the gastric mucosa and which leads to the inflammation of the mucosa, and that's how it causes the gastritis.
What are different enzymes produced by H. pylori?
Proteases, phospholipases, and proteases and phospholipases.
And urease. And
Urease,
urease.
urease,
Protease, phospholipase, and
urease.
urease. Okay. How H. pylori colonizes the stomach?
So actually, it is a first one is it is a flagellated bacteria that helps him to mobilize into the viscous medium of the mucosa. And second, it produces the urease, which protects it from the acidic medium. Thirdly, it has adhesive, which helps him to anchor into the foliolar cells of the stomach. And the fourth one is it produces the toxins by the cytotoxin associated gene A, which uh, is involved in the ulcer or cancer causing mechanism of this bacteria.
Okay. So how would you answer in the exam? You would answer like that. The mechanism involves four different mechanisms: flagella, urease, adhesins, and then toxins. Toxin in the toxins, you can mention CAG-A in the start. Okay.
Okay.
So your answer will be like that. Uh, H. pylori colonizes the stomach with the help of flagella, urease, adhesins, and CAG-A toxin. Toxins.
Okay.
So your answer will be like that, and then you will explain it further.
Okay.
Okay. Okay. So how would it produce? Will cause the ulcer. How would it cause the ulcer?
Sir, it causes the ulcer by producing the toxins by cytotoxin associated genes A, which that is involved in the ulcer development, which basically disrupts the imbalance defensive adaptations of the mucosa, which causes imbalance between the defensive adaptation.
Imbalance. This was the answer. Dr. Sajid, this was the answer. By creating imbalance between the defensive forces of the gastroduodenal mucosa and damaging forces. Okay? This was
Okay.
the answer. How does it cause ulcer? By creating imbalance between defensive and damaging forces of the gastroduodenal mucosa. Okay?
Okay, sir.
Okay. So which type of gastric cancer is caused by H. pylori?
Sir, adenocarcinoma and mucosal associated lymphoid tissue tumor, maltoma.
Malt. Okay. So which immune endocrine disease is caused by H. pylori?
Sir, Hashimoto thyroiditis and malt.
Hashimoto thyroiditis. Okay. What is the eradication therapy for H. pylori?
Eradication therapy for H. pylori consists of BD dose of the following medications for 7 days. Uh, First one is full dose of PPI plus metronidazole 400 milligram plus clarithromycin 250 milligram. Either this regimen is used or full dose of PPI plus amoxicillin 1 gram plus clarithromycin 500 milligram. So
Okay.
one of the following regimen can be used for 7 days in the BD dose.
Okay. Anyone else in a better way?
Sir, can I?
Yes, sure.
It consists of 7 days, twice daily treatment of a PPI, metronidazole and clarithromycin, either or a PPI amoxicillin clarithromycin.
Nice. What is quadruple regime?
Sorry,
What is quadruple regime?
this is the triple regime.
This is the triple regime. What is quadruple regime?
If the triple regime is combined with bismuth sulfate.
Okay. So in quadruple regime, there will be PPI plus metronidazole plus bismuth plus clarithromycin. And in triple regime, there will be any one of these. Okay.
Okay.
So bismuth is combined with. So no, in quadruple regime, there will be bismuth, PPI, metronidazole, and tetracycline. This is quadruple regime. Please note it. Quadruple regime is bismuth, PPI, metronidazole, and tetracycline. This is quadruple regime.
Sir, these are for 7 days or for 14 days?
14 days, not 7 days. These are for 14 days, not 7 days. Okay, so what is the mechanism of action of proton pump inhibitors?
Proton pump inhibitors actually blocks the hydrogen potassium ATPase pump on the parietal cells, which blocks the secretion of hydrogen ion into the gastric lumen that actually combines with the chloride to form the HCl in the gastric lumen.
Okay, that is easy. That's not that difficult. So, what is the action of hydrochloric acid?
Hydrochloric acid activates the pepsinogen to pepsin, which helps in the protein digestion, as well as it has it helps in the killing of the microbiological organisms, different sorts of microbiological organisms, and also helps in the digestion of the activation of the other digestive enzymes.
Okay, so there are two. Number one, it is antimicrobial, and number two, it is pepsinogen, and number three, it is promote gastric secretions. It promotes gastric secretions. Okay, what type of cells are found in gastric antral mucosa?
It consists of simple columnar cells with goblet and mucosal cells.
A simple columnar with goblet cells. That's good. What is the commonest cause of primary hyperparathyroidism?
Hyperparathyroid adenoma is the most common cause of primary
Yes,
hyperparathyroidism.
yes, it is
80% of the
parathyroid adenoma. Parathyroid adenoma. Okay. So what is the mechanism of NSAIDs causing peptic ulcer disease?
NSAIDs, they have an irritant effect on the gastric mucosa. Number two, they actually decreases the blood flow of the blood flow in the gastric mucosa. They decrease the production of prostaglandin synthesis by blocking the cyclooxygenase, and then is the they decrease the repair activity of the superficial ulcers, and finally they impair the barrier properties of the gastric mucosa.
So we will start from the outside to the inner. Excellent, Dr. Sajid. To memorize, just to remember, we will start from the outside to the inside. So it is topical irritant, first of all, to the epithelium, gastric mucosa. Second, that it will cause decreased blood flow, decreased blood flow. And then if there is any damage, it will just interfere with the repair, and towards the end it will decrease the synthesis of prostaglandins are always protective. Okay, so it will just decrease the synthesis of prostaglandins. So you will just start from the superficial and then towards the deep. So because it is the prostaglandin are synthesized, because it is synthesized by the deeper cells. Okay, so the patient is having hypercalcemia. Why the patient is having hypercalcemia?
Sir, the patient is
Yes,
having sir, maybe due to parathyroid. There are three causes of hypercalcemia. First one is it may be due to malignancy, and then hyperparathyroidism and renal failure.
okay. Well, so what is the most likely cause in this patient?
Most likely cause in this patient is
Is
hyperparathyroidism
yes, hyperparathyroidism due to
due to parathyroid adenoma,
adenoma. Why?
because it is the most common cause of primary hyperparathyroidism.
Excellent. Because it is the most common cause of primary hyperparathyroidism leading to hypercalcemia. So it is the most likely cause. So, okay, hypercalcemia causes hematemesis. Hypercalcemia is causing hematemesis in this patient. So, what are other causes of hematemesis?
Other causes of sir, other causes So NSAIDs used, over NSAID
NSAID
use,
use, yes.
and then is this smoking.
No, NSAID use can cause the ulcer, same thing.
Okay.
Ulcer is, one thing is ulcer. That is caused by, ulcer is caused by either by hypercalcemia, NSAID, smoking, whatever. So one is ulcer. What are other causes of hematemesis, not ulcer?
Okay. Other like due to portal hypertension.
Yes, bolo na, Sajid.
Yes, sir. Due to portal hypertension or
What do we call it?
AV
Esophageal.
malformation,
We call it as
esophageal esophageal
esophageal.
varices,
Yes,
varices,
esophageal varices. Second cause, good.
and third one is the chronic gastritis can cause the hematemesis. Then is
Okay,
the AV malformation in the stomach or duodenum, uh,
okay,
and then is the uh, Borhave syndromes.
okay. Borheve syndrome, good. What is Borheve syndrome and what is Mallory-Weiss tear?
Mallory-Weiss tears are the longitudinal tears in the gastric esophageal mucosa, and Borhave's is thus due to sudden over due to sudden and strong vomiting after eating alcohol, after eating a meal or having alcohol. Uh, the sudden cough or sudden or strong cough can cause the uh, tear in the stomach, which leads to the
Okay.
rupture.
So first of all, let us discuss what are different causes of hematemesis. So most common cause of hematemesis is, what is the most common cause?
Gastric ulcer.
Gastric ulcer. One, excellent. Then esophageal varices, either due
Either
to
portal hypertension.
due to portal hypertension, that will be either due to alcoholism or hepatitis C.
Hepatitis
So
C.
that will be liver cirrhosis. Okay. Second one is
Uh,
second one is esophageal varices. Then comes carcinoma, stomach carcinoma. So three
okay.
causes. Then comes esophageal, Mallory-Weiss tear and Borheve syndrome. Mallory-Weiss tear and Borheve syndrome. So there are, so term is Mallory-Weiss tear and Borheve syndrome. Okay,
Okay.
don't change, don't try to change the term. Okay, so it is Borheve syndrome and Mallory-Weiss tears. So what is Borheve syndrome? Difference between Borheve syndrome and Mallory-Weiss tears? Anyone else, please? Dr. Sara, what is the difference between Borheve syndrome and Mallory-Weiss tears? You can describe, I think so, in detail. Yes, Arslan, Dr. Arslan.
Sir, in on Borhave syndrome, there is a perforation of the esophagus, while in Miller-Weiss tear, there is longitudinal tear in the mucosa of the
Excellent,
esophagus.
excellent. That is why I always stress, I will always emphasize to just have concentration on the term. So it is Borheve syndrome. Whenever you use the term syndrome, it means there is not only one problem, there may be multiple problems. So Borheve syndrome, the defect will not be only in the esophagus. So there will be maybe a total mural tear in the esophagus, and that tear may cause
Esophageal perforation.
esophageal perforation, and due to esophageal perforation, there may be
Mediastinitis.
mediastinitis. So that is why we call it as Borheve syndrome. We call it as Borheve syndrome. Okay. So I am just trying to share my screen. Okay. So if this one is the esophagus, you can see. So what is the Bohr syndrome and is this Malraux tear? In the Malraux tear, that defect will be longitudinal. This longitudinal that will that will only cause bleeding. That will only cause bleeding. But in Bohr syndrome, the defect will not be longitudinal. It will be involving a whole thickness of this esophagus, and then when it will cause a whole thickness, then there will be leakage of air, and there will be mediastinum as well as mediastinitis as well as
Um,
emphysema.
emphysema.
Emphysema. So that is why we call it as Bohr syndrome, and the other one is known as
Tear.
Malraux tear. So this is how we differentiate between those. This is very important for your exam purposes. Okay. Okay. So next is what is the mechanism of calcemia causing hematemesis, Dr. Sajid?
So hypercalcemia can leads to the local stimulation of the antral or duodenal mucosal cells, which leads to the increased production of the gastrin, which ultimately increases the production of hydrochloric acid in the stomach, and that leads to the ulcers and
Okay. There is one mechanism that calcium will increase the release of
gastrin. Gastrin production.
yes from G cells. From
Yes,
G cells. So whenever there is more calcium, there will be acted. There will be more gastrin, and it will lead to the hematemesis. Okay. Second mechanism. So there are three different mechanisms. Number one is calcium, that is increasing the production of gastrins from G cells by increasing the sensitivity of receptors, in the G cells. Okay. This is number one mechanism. Number two is parathyroid hormone. This parathyroid hormone indirectly stimulate the gastrin production from the G cells. Parathyroid hormone by itself, by its own effect, not by calcium, by its own effect. And the third one is that so there is a feedback loop of gastrin, and it will involve the increase of calcium, and this calcium will lead to gastrin release. So there are three different mechanisms for hyperparathyroidism or hypercalcemia leading to hematemesis. Okay, so this patient is having why is this patient prone to have renal stone?
due to hypercalcemia.
Due to hypercalcemia. Excellent. Due to hypercalcemia. So what are other findings in hyperparathyroidism? What are other signs and symptoms in hyperparathyroidism?
In hyperparathyroidism, there is abdominal pain either due to acute pancreatitis or renal stones. There is also mood and behavior disturbances, and there is also bony secondary. If there is secondary hyperparathyroidism, then the bone is involved, like osteitis fibrosa cystica, and bone pain is a common symptom, as well as there is soft tissue calcifications. So these are the
Okay,
major
good. So you will say that Dr. Sajid, your answer will be there will be abdominal pain, bone pain, mood swings, and mood changes and renal stones, okay, or urinary tract infections, okay. So these are patients are also prone to have urinary tract infection as well as hematuria. The patient can present with hematuria, okay,
Okay, sir.
due to renal stones. Okay. So now you have done with the parathyroid hormone, and parathyroid is raised. So you have to localize the parathyroid gland. What are different investigations?
Sir, preoperatively, we use the system AB scan,
System
and
investigation. Good.
intraoperatively, we use the frozen section.
Okay. Any other investigation other than these two?
Ultrasound,
Okay. Good. Anyone else?
radionucleotide assay, both system.
Good. Nice. So ultrasound will be yes, Dr. Fasara. Selective venous sampling, but that will not just localize this parathyroid. Yes, yes. So we will start from the ultrasound, MRI, CT scan, and then we will go for system AB scan. System AB, though that is more specific. System AB scan. Okay. So we will start from ultrasound. Dr. Sajid, excellent. We will start from ultrasound.
Thank you, sir.
Okay.
Sir,
So yes,
excuse
please.
me. The question asked to localize parathyroid glands.
Yes.
So for localizing the system B scan is the gold standard.
Yes. Obviously, it is gold standard, no doubt.
But
But will not.
but if
We will,
asked the investigations, then the answer will be beginning from the ultrasound.
yes, we will. So frozen section is not even used for this. Frozen section is not only used for localizing. So we answer that investigations are ultrasound, CT scan, MRI, and system AB scan is the most specific to localize. And then intraoperatively, we will use frozen section. Okay. If asked about the gold standard, it is system AB scan. And if asked about the investigations, then we'll start from the ultrasound, CT scan, MRI. Okay.
Okay, sir.
Yes. So you have seen that there is a prominent spot on system AB scan. Okay. So what is your next step?
Okay, then I will go for the parathyroid hormone levels.
Mhm. Those have been already done.
Okay, I will
So
go
you
for
have
the
done. Yes, you have done with the parathyroid hormone levels. Those were raised. Now you are suspecting that there is parathyroid gland, and you have done the system AB scan, and you have found that spot.
no. I
Okay.
will go
No.
for the surgery of the and then excision of that.
Excellent. One thing is you have to go for parathyroidectomy, but before that, you want to just confirm. Yes.
Sir, FNC.
Yes, we will go for ultrasound guided FNAC. Ultrasound guided FNAC, and then you will go for parathyroidectomy. Parathyroidectomy. Good. Okay. So you said that you will go for frozen section. What is frozen section?
Frozen section is a pathological laboratory investigation which is used to study the microbiological microbiological behavior of the characteristics of the specimen.
Microscopic, not
Oh, sorry.
microbiological.
Micro.
Microscopic. microscopic parameters of the specimen. So what are those microscopic specimens you want to see? You have to mention those microscopic features. Which are those?
Cytology, like pleomorphism.
You have to use a broad term here. Tissue type and
Type and grade of the
tissue type and resection margins
resection.
okay, or extent of resection or resection margins. So on frozen section, what you will specifically see for the section resection margins as well as for the tissue type. Okay.
Okay, sir.
Yes, these two terms. Okay. So how would you fix that specimen?
Uh, Sir, I will fix that specimen on a metal tissue plate, and then
Okay. You have put that on a metal tissue disc or a plate.
on a plate.
Okay.
Then I will secure that chunk, and then rapidly frozen. And then the tissue is rapidly frozen to -20 to -30, and is embedded with the OCP medium, which usually consists of polyvinyl alcohol or polyethylene glycol. And then these sections are frozen cut with keratotome of the cryostat, and they are stained with hemotoxin eosin, and they are then
Okay. So make it excellent, Dr. Sajid. So making it very easy. You will take the tissue, put it on a plate, and that plate is then kept in the freezer, and then in the freezer we will freeze for the temperature of -20 to 30 degree. Okay, there one is done, that we have done it. We have frozen it. Now you have to fix it. How to fix it? You will fix it not with paraffin. Simply, you will not fix it with paraffin. You will fix it with the polyvinyl alcohol. Okay,
okay, okay,
PVA. That's all. That's all. Polyvinyl, and then after that, obviously you will cut it, and then you will and that cutting is done not with the knife. That is got done with the microtome, and then you have to make the slide and staining with hemotoxylin and eosin. So it is written very difficult in the book, but just make it very easy. That you will take the tissue, put it on a plate, and then freeze it. After freezing, you will just embed that tissue in polyvinyl alcohol or polyvinyl uh, chloride, polyvinyl glycol, polyethylene glycol. Okay, and then after the just fixing in that media, then you have to cut it into sections with the help of microtome, and then make the slides and stain them with hemotoxin and eosin. So this will become easy for you. Okay, why are not you using paraffin?
because paraffin takes around 7 days to embed into the tissue specimen.
That's good. And we need it just in few minutes and few hours. Okay. Or and what is the epithelium of gastric mucosa? That is simple columnar. Okay. So there is how many platelets are present in packed RBCs?
Okay, there are no platelets in the packed RBCs
Okay. Why?
because packed RBCs is the purified form of red blood cells only.
Okay. What is different between parathyroid adenoma and parathyroid hyperplasia?
In hyperplasia, parathyroid adenoma is a benign tumor of the glandular structure and in a tissue, while in hyperplasia there is only increase in the number of the cells, normal cells, which is due to the any stimulation.
Good. Anyone else? Oh, sorry. Any other difference? Another difference? How many glands are enlarged in parathyroid adenoma and hyperplasia?
In parathyroid adenoma, usually one gland is enlarged, while in
And
hyperplasia,
other three are normal, or
all
normal or involuted.
stimulated.
Okay.
Yes.
So this is the macroscopic difference, and then microscopic there will be features of
There will be picture of chief cell hyperplasia as well as water clear cell hyperplasia, and oxyphil cells may be present in the microscopic hyperplasia of picture of the hyperplasia of the
in
parathyroid.
hyperplasia. Yes, yes, excellent. In hyperplasia, there will be just increased number of cells that may form either in the form of glands or in the form of there will be diffuse enlargement, either the form of glands or there will be diffuse enlargement.
Yeah.
Okay,
Okay.
and that will be separated by each other by septa,
Septals.
separated from each other by septa. And then in the adenoma, what will be the adenoma?
Sir, adenoma may microscopically usually consist of either uniform polygonal chief cell
Yes,
containing
these chief cells will become polygonal. Chief cells will become
polygon,
polygonal with
small central nuclei,
centrally placed nucleus. Centrally placed nucleus that will be small. And the other
or
form will be
other form will be there may be larger oxyphil cell adenoma.
yes. So if you know the basic pathology, if you know the basic microscopy of the parathyroid gland, then you can easily understand what is the basic pathology. There are about 80 to 85% chief cells, then there are these oxyphil cells, and then there are water clear cells. So in hyperplasia, there is just increase in number of cells, and mostly these are chief cells which are increased. So what happens in this hyperplasia, that there are increase in number of cells, increase in number of cells, and there is one gland, one lobule here, and then there is one other lobule that is here, and these lobules are separated from each other by
Fibrous
septa,
septa.
fibrous septa formation. So this is usually in hyperplasia, but and these cells are usually chief cells. These are all chief cells, but maybe oxyphil cells or clear cells, water clear cells. But in this adenoma, what happens in adenoma? Adenoma, the shape of the cells and the character of the cells is changed. Shape of the cells or character of the cells are changed, and there is centrally placed nucleus, and these cells become polygonal. These cells become polygonal. So this is the difference between these both hyperplasia and adenoma.
Okay.
Okay, so what are the different condition, other condition, any condition in which there you will find hyperparathyroidism?
Hyperparathyroid and chronic renal failure,
Okay, anyone else? Any other disease?
malignancy,
Okay, anyone else? अभी दो दिन
parathyroid.
पहले की पढ़ी बोलते हैं
Parathyroid carcinoma.
What is man 1 syndrome?
In man 1, there is pituitary adenoma, parathyroid, as
Yes,
well as
parathyroid hyperplasia
and islets of pancreatic adenoma.
and pancreatic carcinoma. So
Adenoma.
it is
Yeah.
found in
Man 1.
man 1 syndrome. Okay. The other one is man 1 syndrome. Okay. So if the parathyroid is not found in parathyroid gland is not found in the usual place, that is the in the neck, where it can be.
It can be present in the superior mediastinum
Why?
because the inferior parathyroid glands and thymus both are originated from the third branchial arch, and when the thymus descend in the superior mediastinum, it takes
Yes.
the inferior parathyroid glands along with
Okay.
him,
What
along
is
with it.
the origin of superior parathyroid?
The superior one originate from the
Fourth brachial
fourth branchial arch.
arch. Okay. Okay. So what is the difference between primary, secondary, and tertiary hyperparathyroidism?
In primary hyperthyroidism, it is usually due to the majorly due to the parathyroid adenoma or hyperplasia or multifocal disease or due to carcinoma, and in which there is increased PTH as well as increased calcium, low phosphate, and there is increased urinary calcium to creatinine ratio that is greater than 0.01. And in secondary hyperparathyroidism is usually due to the chronic renal failure in which there is chronically low level of calcium level that activates the parathyroid glands which leads to hyperplasia, and in which we find there is low serum calcium level, and there is also low serum vitamin D level, but there is high level of phosphate and increased PTH level. While
Okay.
in tertiary hyperparathyroidism, the ongoing hyperplasia continues after the correction of the renal abnormality, and we find in the serum there is increased PTH level, and the calcium level may be enlarged or increased or normal. Vitamin D level may be low or normal, but the phosphate level will be decreased or normal.
And one specific thing about tertiary hyperparathyroidism, that
Uh,
is
it involves all the
al-
four hyperplasia of
alkaline phosphatase.
alkaline
Alkaline
phosphate.
phosphatase will be raised. Alkaline phosphatase will be raised. So simple. Primary hyperparathyroidism is the disease of parathyroid gland.
जी जी
Secondary hyperparathyroidism is due to chronic renal failure. Chronic renal failure will lead to hypocalcemia, and
hypocalcemia.
that will be lead to secondarily lead to hyperparathyroidism. And then in the tertiary hyperparathyroidism, this is due to already ongoing. There was a
Ongoing.
hyperplasia of the parathyroid gland, or even after the correction of the renal failure. So, what is the treatment of primary, secondary, and tertiary?
In the treatment of primary hyperparathyroidism is the parathyroidectomy, either
Excellent.
excision of the
Excellent.
excision.
Excellent. One thing.
Uh,
Secondary.
while in secondary and tertiary, we treat the basic cause of the disorder. We treat the CKD as well as we treat the treatment of hypercalcemia
So
tertiary.
what will be the treatment option here in secondary?
In secondary, we
Will it will give to either for dialysis or for renal transplant.
renal
Either
transplant.
for dialysis or for